how do we determine the optimal fluid strategy, especially in a mechanically
Mm.
ventilated patient, and
Yeah.
how do I start with it?
As for so many intervention, of course, it is a bit naive to think that it's choosing between A and B for your patient that is the best solution. I think conceptually the best solution is individualized treatment, but that is easier said than done. So I truly understand that, but that should be the basic strategy. We do know that massive fluid overload is not a good thing. We've learned this. And a lot of studies have shown that when we over-resuscitate patients, that's not a good idea. But this is applicable to so many other things. I know very few things where you overdo them, it brings benefits. But we need to understand, we need to use this in clinical practice. Now, at the same time, I do think there is also still a risk of under-resuscitating a patient. And now I see more frequently patients who are under-resuscitated with also significant outcomes. So this is really this U-shaped curve where you give too much, it's not good. Where you give too little, it's also not good for your patients. I think we do not have to be too afraid to load the patient with fluids initially. I think we've become much more conservative. And what contributed in the past, I think, to this fluid overload is not the fluids that were administered in, say, the first 6 hours, because this is not where you give 10 liters of fluids in 6 hours. It what happens over the first 3 or 4 days. And this continued fluid resuscitation beyond the 6 hours are, for me, the culprits, where we are afraid of over resuscitating the patient, and rightfully so. I mean, we should not be doing that. But conversely, that should not mean that your initial fluid resuscitation should be incomplete, because that in its own right also has consequences. We know from the studies that indeed some of these consequences may be more subtle, like central nervous system effects that may be only detected a few months down the road. But we need to understand that hypoperfusion, and not only looking at the skin, can be very helpful, but also different organ systems may be suffering when we under resuscitate. So finding the right balance, Bharat, it's challenging. I admit, but I also warn against under resuscitation in the first phase, under resuscitating patients, especially, and this is often not considered, some categories of patients who may be particularly prone to being under-resuscitated. You know that I'm a surgery-trained intensivist, and abdominal infections are still one of my major clinical interests. Well, patients with abdominal sepsis, typically, whether they come from the community or from the hospital, have had reduced intake over days, and they typically come with a much higher fluid deficit. They've been vomiting, they've maybe had diarrhea, they've lost a lot of fluids maybe in their peritoneal cavity. And those patients, probably much more than say the 75-year-old patient coming in with the pneumonia or developing hospital-acquired pneumonia, that's a different ballgame. So it's also, again, it's about using your brains. It's about using your clinical insights and not just saying, I will not give fluids or I will give too many fluids, if that's helpful.
So it's very rightly said, as you put it across. The most of the pulmonary edema cases or the fluid overload, what we see is when we continue that kind of a fluid beyond 6 hours for more than 12 hours or 24 hours. So initial fluid resuscitation, the real septic shock patient shouldn't become more of a problem, and we should also be worried about the under resuscitation.
Yeah, so, but of course, at the same time, I think it's okay, and we'll probably see more tendency towards earlier use of vasopressors. If of course, if you see that your first 500 mLs has no impact at all, and especially the diastolic blood pressure remains very low, then that patient has vasoplegia and needs vasopressors. So again, it's about trying to apply physiology at the bedside, and again, resuscitation is very important, but you cannot standardize it for everybody. You need to have your brain, and you also need to look at the patient. You need your eyes.
So you answered my next question. That was the timing of vasopressor. So as you said, if our initial 500 bolus is not working, maybe we can consider starting vasopressors at that moment.